So good morning. I'm Howard Chansky. I'm the chair of the Department of Orthopedics and Sports Medicine, and I want to welcome everybody to our October virtual grand rounds. Our topic this morning is going to be Keembox disease of the wrist and how to approach elephants. And this is being organized and presented by Dr. Zach Walterscheid, one of our R4 residents, Dr. Nick Iannuzzi, an assistant professor in the department, and Dr. Seth Leopold, who is a professor in the department. And before Zach starts, I'll remind everybody that at the end of the grand rounds, you'll be able to unmute yourself and ask questions. You can also use the chat box, one of the Zoom features, and you are also welcome to text Aaron Chirones or myself. With that, Dr. Walterscheid will start our grand rounds.
Well, thank you, Dr. Chansky. So for those who don't know me, my name is Zach Walterscheid, and I'm one of the fourth-year residents here at University of Washington. I have no disclosures, and Dr. Iannuzzi has no disclosures. Dr. Leopold will discuss his during his part of the talk. So just a brief outline of what we'll talk about this morning. So I'll give an introduction and some history in regard to Keembock disease, and then we'll discuss Lunate Anatomy and potential pathophysiology mechanisms, and a few of the modern staging algorithms, including the Lichtman classification, the Schmidt classification, and the Bain classification. And then Dr. Iannuzzi will take over and discuss treatment options, outcomes, and future directions. And we'll wrap up with Dr. Leopold, who will discuss how to approach these issues when the evidence is soft. So just a basic introduction, the lunate is one of the central bones of the carpus. It has articulations with both the distal radius and the distal ulna, as well as multiple intercarpal articulations. Its central position has led many to describe it as the keystone of the wrist. When we talk about Keembox disease, specifically, we're discussing avascular necrosis of the lunate. This is a rare disease. In one study looking at over 51,000 x-rays from a single institution over an 11-year period, they were only able to identify 87 cases of symptomatic Keembock disease and 51 cases of asymptomatic Keembock disease, representing incidences of 0.1% and 0.17% respectively. It tends to affect males more than females in roughly a 3-to-1 ratio, and it's believed to be multifactorial in nature. Various etiologies that have been described have included biomechanical factors, environmental exposures such as repetitive trauma, and features of lunate anatomy such as lunate morphology and lunate vascularity. Typically, patients will present with dorsal wrist pain. On physical exam, they will have tenderness over the radiocarpal joint, and they may or may not have swelling associated with this. They'll also often have reduced grip strength and reduced wrist range of motion. But as you can see, these are quite nonspecific findings. And so both the diagnosis and the staging, which is used to determine treatment, are largely based on imaging studies. In regard to the history of Keembock disease, lunatomalacia and collapse was first described by Pest in a conference in Paris in 1843, in which he described the collapse of lunates that he found on cadaveric dissections. He postulated that these were due to a single traumatic event, but due to the fact that his data was based on dissections and that he didn't have any sort of clinical knowledge of the patients or radiographic studies, he wasn't able to go any further in terms of describing the mechanism. Then in 1910, Robert Kienbock, who was an Austrian radiologist, published his landmark paper describing 16 of his own patients and 20 patients from the literature who had developed lunatomalacia appreciable on radiographs. He found that the patients frequently had an antecedent trauma and that there was a predilection for patients who were involved in manual labor. 10 of the 11 men from his cohort were manual laborers, and 4 out of the 5 women were nurses who had highly manually laborious jobs. He postulated that this was due to disruptions to nutrition of the lunate, but again, he was unsure whether this was a single traumatic event or repetitive microtraumas due to the patient's high level of activity with their jobs. The disease was first termed Keembock disease in 1916 in a textbook published out of Northwestern University. And in 1925, the first review of the literature was done on it by Goldsmith. In this review, he identified 4 clinical stages. The first 2 stages consisting of joint irritation and asymptomatic stage, making up what he termed early disease, and then the second 2 stages being symptomatic disease and the moderate disability stage making up late disease. He recommended conservative management for the early stages and recommended lunate resection for the late stages. Unfortunately, this typically then went on to destabilize the carpus, leading to carpal collapse and pancarpal arthritis. In 1928, Coulton noticed that there was an association between the ulnar variance and the development of Keembox disease when he was studying normal wrists against wrists with Kienbox. He found that in asymptomatic wrists, 60.7% were ulnar neutral, and that the overall variation in ulnar variance followed roughly a bell-shaped curve. In contrast to this, he found that 74% of wrists with Keembox disease were ulnar negative, and that no wrists with Keembox disease were ulnar positive. So he postulated that the ulnar variance may play a role in the development of the disease. He then published a single case report where he performed a radial shortening osteotomy on a patient with symptomatic Kienbock disease and had good results. Then in 1945, Presson added another procedure to the surgical armamentarium by adding an ulnar lengthening osteotomy. He compared his ulnar lengthening procedure with 3 radial shortening procedures and found that he developed either non-unions or pseudoarthroses in all of his radial shortening procedures, leading him to move away from radial shortening and favor ulnar lengthening. It is worth noting, however, that his fixation was simply cerclage wires, so likely his findings were due to inadequate fixation of his osteotomies. In 1947, Stahl presented a second staging scheme, which you can see here, consisting of 5 different stages. He again noted the prevalence of laborers and those who had jobs requiring a lot of manual dexterity and recommended periods of prolonged immobilization. He actually was so highly in favor of this that he postulated that Person's positive findings from his ulnar osteotomies were actually due to the immobilization period needed to heal the osteotomies rather than from the osteotomies themselves. So at this point, even by 1950, we developed an algorithm for treating Kienbock disease based on the understanding of the biomechanics. For those patients who were in the early stages of the disease, physicians could first look at the ulnar variance. For patients who were ulnar negative, a radial shortening or ulnar lengthening osteotomy could be performed. And for those who were ulnar neutral or ulnar positive, immobilization could be performed. Unfortunately, though, there was really no good surgical management for late stage disease. Really, the only 2 options were either lunate resection with resultant carpal collapse or lunate arthroplasty, which relied on a silicone implant, which so frequently created silicone synovitis that it fell out of favor. Since Coulton first noticed the potential association with ulnar variance and Kienbock disease, numerous authors have revisited this topic, and the findings have been quite heterogeneous. Looking at the chart on the left, we can see that numerous authors have found variations in normal ulnar variance in asymptomatic patients. We can look at Gelberman's study in 1975, where he found significant variance just between white and Black Americans in a single time period. On the right, we can see a study from DeHoor et al. From 1993, in which they found that there was actually no association between negative ulnar variance and Keembox disease. They did, however, find that ulnar variance tended to change with age and postulated that this further muddied the waters in determining whether there was causality. 2 recent meta-analyses have looked at this in great depth. The first one by Chung et al. Initially looked at 18 papers and had to narrow down to just 3 papers included in their analysis due to high variation in the way in which ulnar variance was measured and the lack of controls for patients compared from the Kienbock cohort to a regular healthy wrist. And then most recently, this meta-analysis seen on the bottom right by Stephanie Stahl and her colleagues found that there was no association between negative ulnar variance and the development of Kienbock disease based on the best available current evidence. The authors noted that this is a troubling finding, considering that a great deal of surgical intervention is highly predicated on the association between ulnar variance and Kienbock. In order to better understand the etiology, we have to go back to the anatomy, and we can start with the Osseous Anatomy. The lunate is highly covered in articular cartilage due to its many articulations with the surrounding bones. The exception to this is the volar and dorsal cortices. These have insertions for intercarpal ligaments and are where the vascular supplies enter both the volar and dorsal surfaces of the lunate. Multiple morphologies of the lunate have been described. Antuna Zapico specifically noted differences in the angle between the proximal and radial borders of the lunate and described 3 different morphologies. Based on studies of the trabecular microarchitecture, they postulated that this type 1, which is defined as having an angle greater than 130 degrees between the proximal and radial borders, is at highest risk to damage from repetitive axial loads, which may help to explain some of the association between Keembox disease and manual laborers. Also, multiple authors have described the presence or absence of a hamate facet, which we can see in the radiographs on the bottom of the screen. On the left, we can see that this lunate has no hamate facet, whereas on the right, there's a very distinct hamate facet. As we've gone on to further study carpal mechanics and kinetics, we found that it was significantly more complicated than initially thought based on 2-dimensional analyses. And so the exact role of a hamate facet in the development of lunate pathology is not yet well understood. Moving on to the vascularity, we can look at both the extraosseous and the intraosseous blood supplies. The extraosseous blood supplies were well described by Dr. Gelberman's group in the 1970s. They described a rich plexus of vessels developing over both the volar and dorsal aspects of the carpus from anastomoses between the radial, ulnar, and anterior interosseous arteries. From these plexuses, they were able to consistently define 2 vascular supplies to both the volar and dorsal aspects of the lunate. They then went on to inject lunates with latex and study the patterns of intraosseous blood flow, and were able to describe 3 distinct patterns, which they termed I, X, and Y, based on the images that you can see here. Notably, they found that regardless of the pattern, the flow to the proximal lunate was retrograde, similar to what we see in scaphoids, and they postulated that this may help contribute to the prevalence of proximal lunate fractures and lunate AVN in early Kienbock disease. In 1967, Lee performed a similar study looking at 53 normal lunates and found that 26% had only a single dorsal or volar vascular supply, and 7.5% had no anastomoses between the dorsal and palmar supplies. This suggests that in these lunates, there may be an increased risk of avascular necrosis developing if this more tenuous blood supply is affected. In the 1990s, looking at an atlas of, developing an atlas of skeletal blood flow, we greatly increased our knowledge of the venous outflow of the lunate. And Kroc described these very complex subchondral plexuses of veins, which had a very sort of specific anatomic pattern, which was similar to that seen in the distal femur just above the knee. He described plexuses of veins in parallel to one another rather than in communication with another. And we can see in this image in the top right that these veins run incredibly close to the articular cartilage, which is at the bottom of that image, and then immediately adjacent to the subchondral base plate. He suggested that any damage to either the articular cartilage or the subchondral base plate could negatively affect these veins and cause damage to them. And since they run in parallel to each other rather than forming a more robust plexus, damage to any one or a few of the veins could result in significant venous congestion. Based in part on our understanding of the vascular supply to the lunate and on models of femoral head AVN, Greg Bain in Australia has proposed a possible etiology for Keembox disease. In this model, the lunate's initially stressed and there's a physiologic response which results in either local or diffuse hyperemia and edema. This stress can affect either the arterial inflow, the capillary beds, or the venous outflow, and maybe the result of chronic repetitive microfractures due to a high use of the wrist as part of either recreation or vocation. At this point, if the stress is removed, the bone is stable and can recover normally. But if the initial disruption persists, then this leads to edema of the fat cells, which causes tamponade of the sinusoids with possible venous thrombosis, resulting in decreased venous outflow. As the venous outflow decreases, the intraosseous pressure of the lunate increases, ultimately overcoming the pressure of arterial inflow, and avascular necrosis develops. Since the lunate is, again, the keystone of the wrist, as AVN develops and lunate collapse happens over time, we then progress on to pancarpal arthrosis, as is seen. One way of determining where in this process we are is to use the Lichtman classification. And this is really the landmark paper from 1977 that described the staging system that is predominantly used today for determining optimal treatment. It's an expansion on Stahl's 1947 classification system and relies heavily on radiographic findings. In the first stage, there's no distinguishable change on X-ray, and diagnosis relies on more advanced imaging studies such as CT or MRI. On MRI, we can see T1 hypointensities of the lunate, and CT may start to show subtle compression fractures, which aren't appreciable on radiographs, but this can still be challenging in early stages. As we move on to stage 2, the lunate will retain its size and shape, but we can start to see sclerosis and increased lunate density. CT will again show the sclerosis and may begin to show subtle changes in height that aren't appreciable on X-ray. And on MRI, we continue to have T1 hypointensity, but can also start to see T2 hyperintensities. Stage 3 is defined as the period of lunate collapse, and this has been subdivided into stages 3A and 3B based on scaphoid rotation. In 3A, there is no fixed scaphoid rotation, in contrast to stage 3B, where it is. And so on radiographs, we'll see here that we begin to have significant lunate collapse and proximal migration of the carpus, suggesting that carpal mechanics have now been significantly changed. On CT, lunate collapse and trabecular destruction are again noted, and then MRI is defined by T1 hypointensity. In stage 3B, the scaphoid rotation has now become fixed, and one way that we can define this is by looking at the scaphoid ring sign seen in the bottom right of the screen, which is formed by looking down the longitudinal axis of the scaphoid, which is now flexed forward on a PA view. On CT, we'll again see the lunate collapse and MRI T1 hypointensity. And finally, we lead to stage 4, which is characterized by generalized carpal arthrosis in addition to the previously noted carpal collapse. And this is visible on all imaging modalities. In examining the reliability of the Lichtman classification, Jensen et al. Found that there was a high degree of intra-observer reliability in hand surgeons and orthopedic surgeons with interest in hand surgery, but that inter-observer reliability was only moderate. They found that the greatest discrepancy arose in determining whether a patient was in 3A or 3B. And to address this, Chuck Goldfarb and his colleagues at Washington University in St. Louis defined the cutoff point between stages 3A and 3B using the radioscaphoid angle. They suggested that a radioscaphoid angle less than 60 degrees was representative of a 3A Kienbock, whereas greater than 60 degrees represented 3B. And they found that by adding this caveat, they were able to significantly increase the kappa value for inter-observer reliability. The advantage of the Lichtman classification, as noted previously, is that not only does it give us a sense of where in the process of the disease we are, but it can also suggest treatment methods. This suggestion is based really on 2 findings. The first is the stage of the disease as determined by the Lichtman classification itself. And the second is the degree of ulnar variance, where again, we run into this issue of how causative ulnar negativity is in terms of Keembox disease. I'll leave it to Dr. Iannuzzi to discuss this further, but I think it's worth noting that this is one of the main features of this classification system. Another imaging classification system that I won't belabor, but I think bears mentioning, is the Schmidt classification, which is based on gadolinium-enhanced MRI. This doesn't suggest treatment options, but is helpful for prognosis. There's 3 stages to it. In the first pattern, which is termed pattern A, there's an area of hyperemia in the proximal lunate, which greatly enhances with contrast enhancement. The significance of this is that at this point, this hyperemia suggests that the lunate is still viable and that removal of any sort of insults may allow the lunate to heal. But then as we progress, we look to part B, where we again see a hyperemic band, but more proximally, we begin to see an area of necrosis that's no longer viable. And ultimately, this will advance to MRI pattern C, where we see either a large portion or the entire lunate becoming non-viable and necrotic, which will inevitably lead to collapse and carpal arthrosis. And lastly, I'd like to mention the role of arthroscopy in Keembox disease. This was first described by Mentchiari in 1999 when he described arthroscopic debridement of a necrotic lunate and found that there was actually significantly more pathology than was appreciable on imaging. This led Bain in 2006 to create a new system for staging that was based on predictable articular degradation patterns. He found that reliably the proximal lunate first broke down, followed by the lunate facet of the distal radius. At this point, there may or may not be a fracture, which he termed as 2B of the staging system, and then the distal aspect of the lunate and ultimately the proximal capitate. At this point, again, we're sort of comparable with the Lichtman staging for suggesting the development of pancarpal arthrosis. He also recommended different treatment modalities based on the stage as determined arthroscopically, and published these tenets of arthroscopy in Keembox disease, which consist of recognition that synovitis is nearly always present and correlates with the degree of articular cartilage degradation, and that articular cartilage degradation is often underappreciated on imaging studies, such that arthroscopy tends to change the management plan. So just to review what we've talked about briefly this morning, Kienbock is defined as avascular necrosis of the lunate leading to abnormal carpal mechanics. And though we've been studying it for over 100 years, the etiology still remains somewhat unclear, though there are more and more popular postulations now. It can be due to anatomic factors such as vascularity or lunate morphology, but may also have sources from exposure-related risk factors. Multiple staging systems have been proposed over time and rely on both imaging and arthroscopic evaluation. The exact role of ulnar variance is not yet clear, though this still plays an important role in determining the role of surgery in managing these patients. And ultimately, as lunate collapse proceeds, we can reliably predict that pancarpal arthrosis will follow, resulting from changes in intercarpal alignment. And finally, arthroscopy has become more and more popular in addressing this disease, both for staging and for management, and is helpful in determining both this treatment strategy and identifying pathologic features that aren't easily appreciable on imaging. I'll now hand it off to Dr. Iannuzzi. Thank you.
Thanks, Zach. That's a great introduction and a whirlwind tour of kind of the etiology and classification of Kienbock. Zach's done a great job throughout this process, and I think that's evidenced in this presentation. I'm Nick Iannuzzi, one of the hand surgeons here at the University of Washington, and I'll talk a little bit about the treatment and outcomes associated with Keembox disease. So as we go through my presentation, I'd also like to keep in mind the idea of the proverbial elephant when experienced by a group of blind men. Being so large, this elephant was difficult for the men to comprehend the full animal. And so a man who touched the tusk felt a spear, the man who touched the ear perceived a palm fan, and the person who touched the leg felt a tree trunk. I'd argue that we experience Kienbock in a similar way. We'll talk about the natural history of Kienbock as well as the treatment of early Kienbock that's presented in the literature. And as we get into the later stages of Kienbock, we'll start to see this somewhat more fragmented approach. We can review treatment options using mechanical, vascular, and arthroscopic treatment principles. But overall, I'd like to move this talk from a relatively niche area of hand surgery in which we're facing a difficult problem with limited evidence. And I've invited Dr. Leopold to talk a bit about how to address these types of conundrums, which I'd argue each of us faces within our own subspecialties. Before we get too far into this, we should review some of the more commonly used outcome measures in Kienbock studies. These outcomes include some fairly straightforward measures such as the VAS pain scale, grip strength compared to the contralateral side, and range of motion. However, some of the less commonly used outcomes include carpal height ratio and the Stahl index, as well as intercarpal alignment. I'd argue that patients don't really care about these radiographic outcomes, and we haven't established a direct link between radiographs and patient pain or function. But these indices are often used to gauge progression of Keembox disease as collapse to lunate affect the adjacent carpal bones and can be measured using radiographic parameters. In addition, many of the studies will report results as good, fair, poor, and very poor. These outcomes are based on the Evans criteria as modified from Lichtman. And in this measure, patients are assessed using their level of pain, grip strength, and range of motion, as well as whether patients are able to return to their original occupation. While relatively simple, the criteria may vary based on occupation and lack strict criteria for the pain component. So ultimately, I'd argue that this is a relatively outdated form of assessment. The Mayo risk score has also been employed in studies regarding Kienbock, and this score is quite similar to the Evans criteria. And this score hasn't been assessed for reliability, validity, or responsiveness. So we don't have the best outcome measures when it comes to assessing outcomes after Kienbock. And as you'll see, most of these studies are retrospective in nature with relatively limited patient numbers. Overall, the literature surrounding the natural history of Kienbock is relatively sparse. However, in 1980, Beckenbaugh described the Mayo experience treating 46 patients for Kienbock. 10 of these patients received no intervention, of these most ultimately experienced mild pain. They were able to retain their professions with approximately 60% grip strength compared to the contralateral unaffected side. And in addition, they retained about half the normal range of motion in the wrist. The authors noted that while patients did note progression of deterioration on their radiographs, these changes were not entirely or directly linked to symptoms in their limited series. Another study published by Fujisawa in 1996 evaluated 17 patients at an average of 15 and a half years after initially being diagnosed with Kienbock's. And despite undergoing no surgical intervention, these patients experienced similar results with a grip strength averaging 80% of the contralateral side, limited pain, and approximately half the normal range of motion of a normal wrist. And then a final study from Scandinavia evaluated an additional 8 patients and 9 wrists, an average of 27 years after the patients were diagnosed with Keembox disease. These authors included a DASH score as well as a Mayo risk scores in their outcome measures and noted fairly good outcomes with respect to DASH scores. For comparison, there's a Scandinavian study validating the DASH score in patients with tennis elbow had a mean DASH score of 39, which would be considered worse than what was seen in this study. And patients with a hand or wrist ganglion demonstrated a DASH score of 11, fairly comparable to what patients experienced in this series. In addition, it's also known that patients can be asymptomatic with respect to their Kienbock's. At least one study with approximately 1,300 patients who were all asymptomatic and received wrist radiographs found 23 cases of Kienbock's, some of these in the later stages. So again, it's unclear the correlation of radiographs and Kienbock stage to symptoms. So if that's the case, why are we banging drums and honking horns about Keembox disease, and how should we address it as surgeons? While additional studies, including those by Keith et al. And others, have raised concern that Kienbox may continue to progress through Lichtman stages if given enough time, and given the difficulty in treating a fragmented lunate with arthritic surfaces of the radiocarpal and metacarpal joints, we've developed procedures in order to prevent this progression and try to maintain the wrist joint for as long as possible. In this vein, as Dr. Walter Scheid alluded to, Lichtman et al. Developed the following treatment algorithm. This algorithm takes into account a number of factors, including the status of the articular surfaces within the wrist, the presence of fractures within the lunate, and whether or not the lunate appears vascularized. And while comprehensive, I'd argue that surgeons may prioritize each of these characteristics of Kienbock somewhat differently. And the algorithm itself recommends a variety of procedures for similar stages of disease. As such, I'd argue that each surgeon's treatment of Kienbock's may depend on their background and the types of procedures with which they are familiar, as much as the patient characteristics. With that said, early Kienbock's management is relatively consistent for patients without evidence of Kienbock's on radiographs and who are diagnosed only by MRI. Conservative management is preferred. Symptoms may resolve. However, if symptoms continue to persist beyond 3 months, surgical intervention can be considered. The area of further treatment is where we start to get into this idea of Kienbock's as an elephant. So treatment can involve unloading the lunate, revascularizing it, replacing portions of the lunate with osteochondral grafts, and salvage procedures involving fusion. And while the decision of how to treat Kienbock's does involve some patient factors, as I noted before, I'd argue that it's partly based on surgeon factors as well. And so we'll go through some of these options and their outcomes over the next few slides. Focusing on the mechanics of Kienbock's, unloading the radiolunate joint has been commonly employed as a treatment strategy. The reason behind unloading the lunate includes trying to transfer load across the wrist to more normal articulations, and that increased pressure across the lunate may lead to an increased rate of progression of Keembox disease. In addition, we know that workers that participate in relatively high impact activities may have a higher prevalence of Kienbox disease. And in these patients, performing a joint leveling procedure using either radial shortening osteotomy or capitate shortening may be considered. Both radial shortening and ulnar lengthening have been demonstrated to reduce forces across the lunate. Corey et al. Noted a 45% reduction in radiolunate forces across the wrist after shortening the radius 4 millimeters, though they did note an increase in ulnar lunate pressures. However, they also noted decreased pressures upon the lunate of the mid-carpal joint, and ultimately the reported decreased peak pressures across the entirety of the lunate were reduced approximately 35%. Makabe et al. Also evaluated the load across the lunate after radial shortening osteotomy. In their paper, the authors used CT osteoabsorbiometry at a year after shortening to measure the density of subchondral bone as a surrogate for force transmission. The authors noted decreased density of subchondral bone across the lunate facet without an attendant increase in the density of subchondral bone of the distal ulna, and suggested that radial shortening may help decrease the overall load across the lunate. From a clinical standpoint, radial shortening osteotomy is probably one of the most common interventions in the setting of Kienbock's and one of the most studied. A meta-analysis of 17 studies compared non-operative management of Kienbock's to radial shortening osteotomy, and the authors noted decreased pain in the radial shortening group with increased range of motion. Radial shortening may also have an effect similar in some ways to radial decompression, which we'll talk about in a minute, and that the osteotomy itself may result in a regionally increased vascular response. Despite improvements in patient function noted with radial shortening osteotomy, a similar progression towards carpal collapse and arthritis on imaging was noted in the non-op and radial shortening groups. And so patients were noted to have somewhat improved clinical outcomes. It was unclear how well radial shortening actually prevents progression of Kienbock's. Radial shortening is often used in patients with ulnar negative variants, but in patients with neutral risk or ulnar positive variants, capitate shortening is a viable alternative. Gay et al. Evaluated 11 patients at an average of 5.5 years after capitate shortening osteotomy. The majority of patients experienced no pain with improvements in grip strength and relatively good outcomes based on the modified Evans criteria. Following unloading procedures, revascularization of the lunate is also frequently performed in the setting of Kienbock's and may be considered either alone or in conjunction with joint unloading procedures. The goal of these procedures is to try to reduce the intraosseous pressure and restore blood supply to necrotic areas of the lunate. And procedures in this vein include radial or lunate decompression, as well as the use of pedicled vascularized bone grafts. Lunate decompression was studied by Mayo et al. In their study, the authors utilized a guide wire to identify the lunate through a dorsal transverse incision and used a 2.5 millimeter dental burr to decompress the lunate. The authors reported improvements in range of motion, pain, and DASH scores following the procedure, though patients with more advanced Kienbock's required additional procedures, most commonly a radial shortening osteotomy. The authors recommended that this procedure be considered in patients with stage 1 or 2 Kienbock's, though it is fairly uncommon to use this procedure in isolation. On the other hand, radial decompression has been described fairly commonly in the literature. The goal has been described as creating a regional vascular response around the lunate. DeCarli et al. Utilized this technique in 15 patients with relatively advanced Kienbock's and obtained follow-up at an average of 13 years. The authors demonstrated improvements in pain, range of motion, and grip strength, and noted that only 2 patients experienced radiographic progression of disease. In addition, the authors used bone scintigraphy to confirm regional vascular response to develop following the procedure, which may be the basis for revascularization of the lunate itself. Other authors have advocated vascularized bone graft in the treatment of Kienbock's. In their study, Fujiwara et al. Evaluated patients an average of 12.25 years after various vascularized bone grafts were used to treat advanced Kienbock's, either stage 3A or 3B. Patients noted improvements in range of motion and grip strength compared with their preoperative evaluations. And in stage 3B patients, improvements were also noted in their radiographic parameters. Of these vascularized bone grafts, one of the more commonly performed grafts includes a 4-5 extracompartmental artery flap. This can be performed either by dissecting the perforator itself or by leaving this area of bone attached to a portion of the wrist capsule, including the dorsal vessels crossing the wrist, as described by Dean Soterianos. In his report, Santos evaluated a series of patients from 3 separate studies with an average of 45-month follow-up and noted improvements in grip strength, pain, and range of motion. Revascularizations, whether by cord decompression and transfer of vascularized bone grafts, have demonstrated relatively good results in the literature, including in some patients with relatively advanced Keembox disease. For surgeons familiar with microsurgery, the transfer of osteochondral tissue provides another avenue of Kienbock's management. The goal with this treatment is to replace a non-viable proximal lunate, which may be flattened or demonstrate early arthritic changes. Replacement of the lunate with a titanium implant has been utilized as silicone has fallen out of favor. However, this treatment is relatively uncommon in the United States. Osteocondyle transfer, and particularly transfer of a portion of the medial femoral trochlea, has been a relatively recent development in the treatment of Keembox disease and has provided an alternative form of partial lunate replacement. Titanium implants, as opposed to silicone, have been used to replace the lunate after silicone implants were noted to cause synovitis. The Kaja et al. Out of Finland were able to demonstrate relatively good grip strength, range of motion, and dash scores at an average of 11 years follow-up after titanium lunate replacement. The authors noted dislocations of the implants in 2 patients, each noted to have poor results following complication. 1 patient requested no further treatment, while the other ultimately underwent wrist arthrodesis after removal of the implant. But I'd argue that this is relatively rarely performed in the United States. The development of medial femoral trochlea free flap by Heinz-Berger has allowed microsurgeons to forgo artificial implants and to replace diseased portions of the lunate using vascularized bone and cartilage from the medial aspect of the knee. Though most reported follow-up is relatively short, patients were able to demonstrate relatively low levels of pain and improved grip strength following surgery. Follow-up studies subsequent to this procedure have also demonstrated continued viability of the chondrocytes and the transferred tissue over a year later. Here's an example of 1 patient treated here at the VA at Puget Sound using a medial femoral trochlea free flap. The patient presented to clinic at 29 years old with wrist pain and decreased range of motion. Radiographs demonstrated grade 3A Kienbock with some additional fragmentation of the lunate. After a discussion of proximal row carpectomy, arthrodesis, and medial femoral trochlea free flap, the patient elected to proceed with an MFT graft. At 2 years and 3 months, the patient was noted to have range of motion similar to pre-op, though wrist pain and grip strength had improved, and no further fragmentation or radiographic progression was noted. In addition, he noted no knee pain, was overall pleased with his result. In the later stages of Kienbock, and particularly when there's concern for degeneration of the articular surfaces, arthroscopy can assist with operative decision-making. By visually assessing the condition of the joint surfaces, the surgeon can tailor the treatment to fit the patient in their precise condition. Following arthroscopic assessment, treatment may consist of any of the options we previously discussed, as well as salvage options, including partial wrist arthrodesis, proximal row carpectomy, or total wrist arthrodesis. Arthroscopy is usually performed in a dry fashion and utilizes both the midcarpal and radiocarpal portals to assess the wrist. Patients should be evaluated for loose bodies, degeneration or fragmentation of cartilage, or subchondral fractures. And in the image above, we can see a relatively preserved proximal pole decapitated, as well as a denuded surface of the distal ulna consistent with stage 3 wrist as described by Bain. In this setting, scaphocapitate arthrodesis could be considered, as well as could be considered arthrodesis of the entire wrist. So what are the takeaways thus far, and what do we do next? I think this passage from Alice in Wonderland sums up our predicament with respect to Kienbock quite nicely. And in this passage, Alice is speaking with the Cheshire Cat and states that she doesn't really care where she goes as long as she gets somewhere. And the cat replies that that's sure to happen as long as you walk far enough. So what do we do? So we know that treatment for Keembox disease may decrease pain and improve function to some degree, but do we really know whether treatment for this condition provides considerable benefit compared to the natural history of the disease? Much of the difficulty in assessing treatment efficacy is due to the retrospective nature of the studies that have been published, as well as the small patient numbers that are presented. One published study has tried to address these deficits using a different form of statistical analysis, in this case, Bayesian analysis, in order to evaluate outcomes following various treatment for Kienbock. The concept behind Bayesian analysis is that management of a condition may result in outcomes that fall along a bell curve of probabilities. With each study, that bell curve may shift slightly depending on what outcomes are ultimately observed. And as data accumulates, you continue to shift this probability curve in order to fit the observed outcomes. As opposed to relying on an a priori definition that a p-value of 0.05 is significant, this allows the researcher to accumulate data in real time and may be helpful for relatively rarely observed conditions such as Kienbock. The authors in the early group of Kienbock noted that pain, grip strength, and range of motion were likely to improve with both vascularized bone grafting and unloading procedures, while radiographic outcomes may also improve with unloading procedures. In a late stage Kienbock group, the authors noted that vascularized bone grafting, proximal row carpectomy, unloading procedures, and tendon ball arthroplasty would improve range of motion and grip strength, but not necessarily affect radiographic outcomes. So pain may be improved regardless of treatment. Early Kienbocks may note improvement of range of motion, grip strength after vascularized bone graft and unloading procedures. And late patients may note improved range of motion for all except partial arthrodesis and non-surgical management. So where do we stand? Unfortunately for scientists, but fortunately for patients, Kienbock remains a relatively rare condition, which makes it somewhat difficult to study and makes it difficult for us to understand the entirety of the condition. We know that many various treatments improve pain as well as some aspects of wrist function, but it's unclear how much better these results are when compared to the natural history of the condition. It's possible that with improved study design and possibly with lesser reliance on our commonly accepted p-values, we may be able to obtain a greater understanding of Kienbock and the outcomes. But in the meantime, what should we do? And how should each of us address our own elephants within our field? And with that question, I'll turn to Dr. Leopold.
Well, good morning, and thanks to Zach and thanks to Nick. As soon as I figure out how to share my screen, we'll get started. So, let's see. Can you see it okay?
Would you mind going to full view? There you go. Looks good.
Okay, great. So Nick and Zach, thank you very much. And thanks for the invitation. It makes perfect sense to have a hip and knee guy here talking to you about Keembox disease. But I think we'll probably take a step back and look at things a bit more broadly. As Nick alluded, I'd like to talk a little bit about what to do when our evidence is soft. And so my disclosure principally here is that I have contract salary support from the journal where I work. I guess the other disclosure is that I don't know anything about elephants. And prior to 45 minutes ago, I didn't know very much about Kienbock either. The question is on all of our minds is how to answer our patients' questions when we lack data. And we could talk a bit in the Q&A about Bayesian approaches, which Nick mentioned may be better than frequentist ones for this one, for problems like this. The problem is lack of data is lack of data, and Bayesian approaches have their own issues here as well. The big picture is how do we answer questions when we lack data? And if I could answer this, I wouldn't be an editor, I would be a seer. So let me tell you what little I know about Kienbock disease. We don't know if it's active when we diagnose it. We don't know its natural history. We don't know if any of our treatments are disease modifying or palliative. And the condition is so uncommon that we probably never will. And so Kienbock, though, is not unusual in this regard. The same points can be made about many of the conditions that we treat. And so what we've got to deal with together as clinicians is what do we do when we're unsure? And if we're paying attention, that's most of the time. Most studies, in fact, more than 90% of studies in leading orthopedic journals on treatments are retrospective. Retrospective studies characteristically have the same kinds of bias, selection bias, where the groups that you may be comparing are dissimilar at baseline in ways that can influence the outcomes that you care about. Transfer bias is the issue of follow-up not being sufficiently long or complete to detect all of the relevant harms of a treatment. It's even worse if there's differential follow-up between the groups you're comparing. Assessment bias, generally speaking, and in I think almost all of the surgeons, in almost all of the studies that Nick mentions, the surgeons are grading their own work and often using non-validated tools. What you need to know about those biases is that they don't offset, they're additive. And so they all tend to inflate the apparent benefits of the treatment that we're looking at, or the novel treatment if two treatments are being compared. These biases make us look better than we are. And so I'm going to give you a couple of examples of how transfer bias can influence our thinking. So this would be an extreme example in an unusual case. This is from a pediatric orthopedic surgeon who was presenting at M&M when I was a resident. He had invented a new treatment for tarsal coalitions. He hadn't published on it. He was just doing it. He said that he invented a new operation. He did 7 of them. None of the patients came back, and he surmised that they must be doing okay, of course, except for the one who was being presented in M&M that day. So this is, I think you can see the problems with that. But let's look at a more typical example that's an everyday thing in general orthopedic clinics. Let's talk about knee arthroscopies in patients with degenerative joint disease or meniscal tears in middle-aged adults. Typically, the follow-up from the arthroscopist is until the post-op pain is gone, maybe 6 weeks, maybe 12 weeks. And the question is, how can you possibly know whether the operation has helped? If you don't follow the patient for 2 years, and who does, you don't really know, because it takes the patient a few months to get back to normal, or try to. But let's say the patient doesn't get back to normal, it takes them a few months to figure out which arthroplasty surgeon to see, a few months to get off the wait list and get an appointment, and a few months to schedule surgery. And by then you're at a year or two, which is the follow-up you should have if you want to make claims about this operation. Truth is, unless it's been done in a study, we don't really know whether this operation works. And this is pretty commonly done in our profession, about 750,000 of them done a year in this country. Making things worse are claims by people like Ioannidis, who's done some math to suggest that a lot of what we read in journals isn't true. He may be right. Many of the conditions we treat are uncommon, like Kienbock's, and they're impossible to study with the rigor that we'd like to apply. Case series, such as the ones we've been hearing about, are terribly susceptible to placebo effects. If you haven't read the interview a couple of months ago with Ted Kapchuk, who may be the only person at Harvard who's a full professor without any kind of advanced degree, surgical placebos are about 50% of patients improve. Pharmacologic placebos about a third. This should influence our thinking when we're interpreting the kinds of studies that Nick was presenting. Other things that make things worse, there's something called the Kruger-Dunning effect. Stated otherwise, we all believe we're better than average drivers or better than average kissers. More scientifically, they've done studies about knowledge and beliefs. And an example published recently, the less a person knows about vaccine science, the more certain she is that the vaccine recommendations are flawed. Surgeons, being people, almost always and almost certainly overestimate the quality and strength of the evidence in support of their own views, the efficacies of their treatments, and their own abilities. So looking at this helps us to answer the question, when are we good enough to try a new surgical approach? And the answer is usually it's later than we think. If you add in some problems of process in terms of how knowledge gets generated and shared, most studies of new devices and approaches seek to show that they're as good as existing ones rather than better than. And this has a number of shortcomings because new is usually more expensive. New is almost always has the uncertainty of novelty. New may deliver unintended consequences, such as we saw in the spine with our HBMP and the hip with metal-on-metal devices and so forth. And so our ability to know, really to know whether we're helping somebody with an operation or any other treatment that we might offer is much more limited than we usually acknowledge. So this is bad news. I'm a journal editor. I can't fix this. You can't either. So what do we do? And so, initially the impulse might be to throw in the towel, but I would say we got some other choices. And I'm intentionally keeping this talk short because I think the Q&A is going to be more fun. I think we can apply our best professional values here of integrity, intellect, modesty, and empathy. We need to know in terms of empathy that symptoms and diagnoses and X-ray findings all can cause emotional distress, as can uncertainty. And our profession is, as they say, full of it. So it takes time and care to address uncertainty and emotional distress. We have to make that time and space in our office. Not doing this worsens health. We're supposed to be about improving health. Not doing this makes it harder to help our patients make care decisions that are consistent with their own values. So very briefly, a line on each. Integrity, when we're unsure, we have to say that we're unsure. And when we're unsure, we have to weigh heavily the possibility that our treatment may cause harm as well as help. Intellect, we need to get savvy about effect sizes rather than focusing on p-values. The minimum clinically important difference is a good tool. It's not the only tool to look at the effect size of a treatment. You should have a sense for how big an effect size on an outcomes tool that you use how big it has to be for it to be important to a patient so that you can read your journals more thoughtfully and give patients better advice. We need to lose our slavish affection for sexy p-values, as Nick alluded to, and we need to focus on endpoints that a patient may care about. Patients aren't going to notice a 2-degree difference in tibial alignment, and so we may not need a robot to deliver that. You could say the same thing in Kienbock for fractions of a degree in the stall index. We should be looking at things like pain and function and survivorship. How about modesty? The placebo effect is, whether you like it or not, a part of your surgical result. It's especially big when our evidence quality is low, and that should inform our decision making in ways that tilt us away from surgery, not towards it. We're not trying to leverage the placebo effect here. We should be mindful that there are safer ways to get the outcomes we desire than exposing people to surgical placebos. Empathy. Words like failed non-surgical treatment should not be part of our lexicon. If you have a patient who you think has, quote, failed non-surgical treatment, instead of suggesting surgery, think about the word adapt and try to use it in a sentence today with at least one of your patients. Don't just say it, make thoughtful suggestions for how to do it. And with that, I'm going to turn it over to the Q&A. And thanks for the invitation.
Thanks, Seth. That was great.
Are there any comments or questions? I think it's you guys did such a great job covering this disease, and as we know, the less certainty we have about anything we treat, we tend to come up with more and more complex grading systems and more complex surgeries, and you really covered this very broadly.
Thanks, Howard. This is Seth. I think the concept of grading systems is something we didn't have time to get into. I think we ought to view those with deep suspicion until or unless they've been validated, not just by their originators, by others. Almost all of the grading systems that have been assessed have fallen short. And we use grading systems. We use grading systems for a host of reasons. We use them to communicate with one another, to anticipate prognosis, to determine treatments, to do research. And if a lot of the grading systems you saw today were characterized as moderate or good reliability with kappa values of 0.6, a kappa value of 0.6 means a substantial portion of the cases assessed had disagreement among the observers, which means you can mislead one another in terms of communication, research, prognosis, and treatment decisions.
Yeah, I think people that develop these grading systems, they're well-intentioned, but there's also, in a sense, a lot of pressure on us to develop grading systems. It's kind of become the paradigm, for how we approach so many problems in orthopedics. You can build your career off of a grading system and then find out, 15, 20 years after you retire that perhaps it really wasn't as good as people thought it was, or as useful as people thought it was. And so I don't know about other surgical fields, but I always have this sense that within orthopedics, we really are somewhat overwhelmed with grading systems. And if they worked, it would be wonderful.
Seth, Paul here. I realize this is going to be a little bit of waving a red flag at you, but what do you do when there is a reasonable body of evidence against a procedure and people do it anyway?
Yeah, you're teasing me, Paul. We're working on an editorial about the Academy's new guideline that endorses arthroscopic surgery for degenerative meniscus tears, for a procedure for which there's literally no strong evidence in favor and numerous randomized trials against. And the Academy just updated its guidelines suggesting that this is an okay thing to do for patients.
Seth, I'm gonna add to that to get you going even more of that. The Academy also endorsed, PRP injections in a way that really, in my opinion, does not at all comport with evidence or biological plausibility even.
Right. Yeah. And actually, there was a line in that editorial that Paul and others encouraged me to take out about commenting on that PRP issue. I think since Josh Jacobs was the president of the Academy, after he left, they have not recommended against any procedure that their fellows can get paid to perform. And I think that influences to some degree these guidelines, maybe more than we'd like to acknowledge. Paul, what do we do in that situation? All you can do is be like the guy in Tiananmen Square, I guess. You got to stand up and say the right thing, whether you're in a conference or if you've got an editorial podium or if you've got a position of authority at the Academy. We've got deeper obligations than we're now respecting. But right, the new guideline on arthroscopic surgery for meniscus tears in middle-aged adults is a travesty.
And I think the hardest part might be we have a sense what's right, but it's really difficult when you have a patient in clinic who's truly hurting. There's no really effective treatment. And the tendency on, the patient's part and our part is to just try something. It's done out of a sense of compassion. It's, we're not doing it because we know it won't work. I think we approach that optimistically, but the evidence suggests that any degree of hope or optimism really isn't warranted for some of these treatments.
That's exactly right, Howard. Sometimes it's a don't just do something, stand there moment. And while you're standing there, open your ears and open your heart and look the patient in the eye and, ask them about other things. These are connecting and empathy moments. And there are times when Howard, you as a person who started out as a tumor surgeon know better than I do. There are things we can't cure. And sometimes healing isn't about curing. And sometimes it's about walking alongside people and understanding what they're experiencing and trying to support that, even if we can't specifically fix it as an anatomic problem. I see in the chat, Klein asks the question, how do we balance innovation with uncertainty of benefit? And I guess the theme of the day is baiting me. Thank you, Klein. So I think the answer is you balance it in the context of a trial. There are too many things that we don't have sufficient evidence to use that are in common use and practice, and they're expensive. They have the uncertainty associated with novelty, and we're working this stuff out on the go in our patients' bodies rather than in the context of trials. I guess the only exception I'd say to that claim is if our available treatments are terrible, then we have to be a little more permissive and maybe a little bit more willing to accept exploration and experimentation and solution. If somebody had a solution for infected pelvic discontinuities and arthroplasty reconstruction, and it seemed promising, we should be somewhat more open to that than somebody who's developing another suture anchor or another condylar knee replacement. We're awash in those, and we don't necessarily need any more of them. But I think most of the innovations we've seen, a large proportion of them are steps sideways or steps backward than steps forward. And so I think the clinical trial is the right place to cover that. Rick Mattson writes a lot about this, and I see he's on the call. I'm wondering if he wants to comment on Klein's question.
Well, again, enjoyed the presentation. And the point I'd like to make is that each of us has an opportunity to follow her or his patients, as Codman says, long enough to figure out whether or not the treatment worked or not. And what I've found in my own practice is the greatest opportunity for learning is studying the patients who did not feel that they were improved. And you can't do that if you are casual or reckless about how you follow your patients. As was given as an example earlier, the fact that people don't come back and complain is not a good metric. And as Nick has emphasized, you have to have some sort of clinical outcome tool that emphasizes what's of value to the patient. And that usually does not include things like range of motion or radiographic appearance. And you have to follow those patients and look at the ones that did well and the ones that did not do well. And that can apply to operative or non-operative treatment. The incentives for always trying to do something new and different is interesting and sometimes powerful. But again, my view is if I've got something that works for most of my patients, I'm going to continue to do it until there's enough evidence to switch to something bigger, more expensive, or more aggressive. So my hope is that all of you will carefully follow your own patients using metrics that focus on the patient and really do a good in-depth analysis of the patients that did not do well.
Dr. Mattson, I think you're also telling us that experience is really valuable, particularly when we have diseases and treatments that we're so uncertain about. Sometimes, 25, 30 years of practice is as every bit as valuable as what we can glean from confusing literature.
Yes, and I'm trying to make one other, thank you, Howard. I'm trying to make one other point, which is that the fact that something works for the doctors at the Vail Clinic does not necessarily mean that it's something I should do. And I want to make sure that I am the master of my own craft and that I'm good at doing what I do. And even though Seth and I argue about this from time to time just for fun, but I still believe that the surgeon is the method. And that means the surgeon is the person that helps select the patient for the treatment and carries out the treatment and follows the patient afterwards. That has a huge effect, which is very, very difficult to analyze in the literature, but we all know that it's a strong effect, that some people can do operations and make them work. Some people can select patients appropriately and not. What really counts for each individual is that they are true to their own self about who they do the surgery on, who they do the non-operative treatment on, and carefully analyze their own results.
Those are great points. The way experience weighs in here is so important, and you do it right. It's people think they're following their results by just mathing out average scores for the patients who've reported back. You take specific pains to track down the missing, and the missing is really where the secrets are. What we think we know isn't always right. We saw this today in the comments about ulnar variants and Kienbock. We've seen it for hooked acromions, black discs, degenerative meniscus tears, all of these things that we've organized treatments around. And then found that they work based on the people who came back to tell us how they were doing, which is what so many of these studies are like, right? Case series are all about who comes back and tells us how well they're doing. You start to put yourself into a situation where our experience becomes a source of framing and confirmation bias. Your research is so special because you're the rare person who tracks down the missing, but you've got to be especially careful to account for that factor.
And
I see. Oh, sorry. Go
just
ahead.
one other quick comment. One of the phrases that I had not been as familiar with as I should be, and I think it applies to all of us, is something called non-response bias. In other words, we all say, gosh, if I get, 67% of my patients back in the office for follow-up, then I've got a good handle on how my Kienbocks did with my favorite procedure. But that leaves fully a third of them that have unknown outcomes. And I'll leave it to your own imagination why the non-responders may have been non-responders. People get at that by comparing the preoperative characteristics of the responders and the non-responders, but that's not sufficient because that doesn't include the people that got infections and after my lame attempt to treat their Kienbocks and went to Nick for follow-up treatment. So the non-response bias is hugely important, and very few of the studies that we have both long-term follow-up and a low level of loss to follow-up.
Thank you. I see Doctors Wong and Hanel still on the call and wonder if they have any comments on this talk or on how to treat Keembox disease.
I'll go first because the more time I spend with this subject, the less I know. And I don't think there's ever been anything more, any subject in orthopedics that has had more written about it and has so few number of patients population. And that I think the things that come into this is the one thing that was touched on a bit is we usually people that are not as good as Rick Mattson and do not meet the criteria of following every patient and finding that outcome. What we do and what we tend to do is we look at our last experience and the last patients that we had with this disease entity and how we treated it. And if it went well, we repeat that. And if it went poorly, we don't. And we look for another method of management. And I'll readily admit that if I see something beyond stage 2, the stage 2B in the staging practice, if I see sclerosis or fracture or degenerative disease, then my treatment is live with it until you can't stand it. And then a reliable relief of your pain can be brought by fusing the wrist. And as a result of, and infusing wrist, then I think that we take and we address the pain, but we don't ever say or I never say that I improve the function of the patient, other than the fact that when you relieve pain with a particular activity, the relative strength of that extremity improves because the patient uses that extremity. So I think it's a great lecture, and it's encyclopedic in its presentation. And I think this does become a good starting point for residents and fellows who are going to look at this for the next 30 years of their lives. But I can tell you, after 30 years of looking at this, I'm probably back to base one.
So, Jerry, and Dr. Kennedy is also on, and maybe Steve also has some comments.
Right. Thank you, Howard. So first of all, great talks and great discussion points. I think really great example of disease where everything kind of works, but nothing works perfectly. We also know that we do offer treatments that provide pain relief, but we really can't reverse the disease process. I think so. The question is for Dr. Chansky, Dr. Matz, and Dr. Leopold, is the example of a disease where we choose the least invasive and the simplest operation, or do we throw everything in the kitchen sink at it, where we do unloading, revascularization, do everything we can to try and make it better? Or do we do just a simple core decompression or arthroscopic synovectomy, which is kind of what I lean towards really in my last couple of years, is do something that's reliable and simple, knowing that you're going to have a similar outcome. I think the other point with Dr. Matson that he brought up was great, is looking at the negative outcomes. And we know that 70, 80% of patients do well, that 20% doesn't do well. How do we really kind of break that down and find out why they didn't do well? I think just be honest with the patient. I think I just had a patient yesterday with Kienbock, trying to decide on treatment, and literally just had a whole discussion with her. At the very end of it, the conclusion was really there's no best treatment option, but you explain the rationales, why we do what we do, and really come to a mutual decision-making process as far as what's best for the patient. I think, but great discussion points and great talks by everybody. Thank you.
Steve?
Yeah, I thought it was an excellent review. I really appreciated all those details. It was a great update, specifically on Keembox disease. I thought it was remarkable with the words that we use. So the in the concluding sentences by Zach, he commented that we define Keembox disease as avascular necrosis of the lunate, but then commented that we don't actually know if it's avascular. And so, should we even be using the term avascular necrosis for this condition? And I think there's lots of conditions in hand surgery and in orthopedics where our terms have changed. Epicondylitis comes to mind. There's very little inflammation associated with epicondylitis. And so these, when do we start, formally changing these terms? And because we're basing our research on 100 years of experience, and the words matter. I think that there's a continuing. I think that the discussion about empathy and discussion with patients about the limitations of our knowledge is valuable to all orthopedic surgeons, and I really appreciate that. This presentation went from the microcosm of hand surgery to the whole breadth of medicine in general. So thanks.
Thank you, Steve. It's interesting that it's gone from cadaveric dissections to X-rays to CTs, bone scans, MRI, CT absorptiometry. And it's almost as if the more, we learn about the disease through advances in technology, nothing still has changed in terms of our ability to really understand the pathological process or develop effective treatments, which I think goes back to Steve, to your comment about calling it avascular necrosis. All that expensive technology.
And we still can't see the elephant. So
What's that, Nick?
We still can't see the elephant.
Yeah, it's interesting.
Well, last week was the American Society for Surgery of the Hand meeting.
There you go.
And to that extent, there was some pretty definite people there. It was no doubt that they had the answer to this problem. Again, based on case series. And I forewarn all of us after meetings like that to be humble, and humble with your patient, humble with yourself, and say, if I do what I was just told to do, are my patients going to get really better? And I fall back into the Matson camp in that you better have a good reason to do something, and you better be willing to make a verbal contract with a patient that you're going to follow them till the end. And that means 5 years out, 10 years out, looking at what happens to these people, so that if we have these, we can tell people that, yes, this is what I know about this particular disease, and this is how many years I think you can get out of the procedure I'm about to suggest for you.
I have one other question for the hand surgeons. Just going back to my last comment about technology. If you just artificially restricted yourselves to physical exam and X-rays and avoided MRIs, CTs, do you think you could treat the disease and your outcomes would be similar as when you're given the opportunity to order all of those other expensive studies? Do they really, given this conversation, do they really add anything to the benefit of the patient?
Howard, this is Seth. Before you get to the hand surgeons, I have to excuse myself to go drive to clinic to be uncertain all day. But I wanted to thank you for the invitation and Zach as well. But I didn't want to duck out without being impolite. Yeah,
that was great, Seth. Thank you for joining us.
Thank you, Seth.
Have a good day.
Bye.
To answer your question, Howard, I operate on less Keembox disease based on findings from MR scans. And if the MR scans demonstrate vascularity within a intact lunate, then I encourage people to live with it, to splint it, to see if they can live through it. And having done that, I have a limited number of patients. I can name 4 that have followed that advice. I know a lot of other patients that didn't follow that advice and went elsewhere and chose to have some intervention. But if I have an MR scan that demonstrates vascularity to an intact lunate, even though the X-rays look like a stage 1 or 2, well, they look like stage 2 or 2B, I will leave those alone and not operate on it.
That's a great question by Dr. Chansky, as far as does the advanced imaging and some of the innovation help. I think the biggest change as far as how we see these is really based on the articular cartilage. I think in the past, the ligament classification based on amount of lunate collapse. Now we're looking at the distal and the proximal lunate morphology, what it looks like, whether it's arthroscopy or MRI. I think for me, that's where it plays a role. I think if you have intact cartilage shell, you could try and do some way of trying to save the lunate, whether it's revascularization, trying to shorten the lunate. I think once you have articular cartilage damage, you're looking at more a salvage procedure. So I think it does play a role. But I think majority of these, we are probably over imaging and probably getting the more studies than we really need. But I think I don't know the right answer. I think it goes back to the theme of the talk is we don't know, are we really helping the patient by offering them all these innovative techniques and procedures, or should we take a step back and offer more just cast mobilization, symptomatic relief, and arthroscopy or something very simple where we offer some type of decompression, but not some of the bigger and fancier procedures that are described out there.
Yeah, any final comments before we wrap it up from the hand surgeons? No? Okay. That was really excellent. Zach, thank you. You you assimilated an incredible amount of confusing information and really presented it well for an audience that never treats Keembox disease. And thank you also, Nick Iannuzzi and Dr. Leopold. That was excellent. So everybody have a great day. See you soon.
Thank you.
Yeah.
Everybody.